I think my talk is more of advocacy. So I am basically a microsurgeon, so I'm involved in all the micro part. So this is a work done by Dr. Raja and our oncosurgeon, who is a well-trained oncoplastic surgeon also. So this I showed in the morning. So we have two situations where we can do a delayed reconstruction as shown by just now shown. So this is a case where we did a DIEP. But then always it is not possible to do DIEP in many cases. And this also I showed a delayed presentation with LVA. Now if you don't have a DIEP option, what are the other options? So especially if there is a scarred abdomen or if the abdominal volume is very less. So these are the two instances where we may have to go look beyond DIEP. And we have been doing a lot of gracilis in our department for trauma. And tug flap, now actually it has become a dug flap, more diagonal than transverse. This is a go-to flap when you don't have enough volume. So the way it is done is you create a pocket, and we always do an ICG before this because we should not end up leaving behind skin which will not survive later on. The advantage of tug is you can do a nipple areola reconstruction in the same sitting. So we harvest one side while the other side, the other surgeon here, Dr. Raja, so he's been making the nipple areola complex. You can exactly match with the specimen, and then you can bring in both the flaps. We do the anastomosis both in the internal memory and in the latissimus dorsi, whichever is preferable, whichever you can give. You prefer not to take both the internal memory, so one side lat dorsi and one side internal memory. So this is how it looks. This is on immediate post-op. We should actually avoid scratching the flap, because if you have done a primary nipple areola and try to scratch the flap for seeing monitoring, so this after this case we stopped doing that. So this is how they look. Enough volume has been achieved, but still the volume is not as good as a classic DIEP flap. So why oncoplastic surgery? This because the survival rate has increased and more patients want primary reconstruction. And this is a PRS article published by Dr. Raja. And when we did a survey it was a telephonic survey done to more than 10,000 women in India, and they found that 77% of women feel depressed after mastectomy, so they do need reconstruction, and 76.5 women preferred breast reconstruction, of which most of them preferred autologous over implants. So this is a key factor which drives our oncoplastic reconstruction. So ideally all oncosurgeons, already we saw, have a plastic surgery or reconstructive knowledge and concepts, and similarly all plastic surgeons should have the basic oncoplastic concepts in breast reconstruction, which is ideal. And what is the need? So whenever there is to increase the indications of breast conservative therapy, we will need to have more partial defects where the other techniques will be useful. Otherwise, if you don't take care of volume, we have been talking about it from morning, if you don't take care and think that it will settle down, we will get very poor aesthetic outcomes like this. So when will breast reconstruction become popular? When it is both high quality as well as affordable. I think that is the key. So when do we do conservative? I think this I will skip, all of us know, but when do we do reconstruction? When the volume is more than 20% of the breast, I think you should go for reconstruction. So types of oncoplasty you can have for volume replacement and both volume displacement. So we'll see some example. So we have done a therapeutic mammoplasty. We can do simultaneous excision as well as reconstruction in the same sitting. And this is a post-op result of the same patient. Volume replacement techniques, LD is a classic option. So 50-year-old lady, and that's a lump. So that's a volume which has been excised, or the tumor which has been excised. So here you have a choice of how do you reconstruct. So latissimus dorsi is very good. We try to go through the periareolar incision, remove it, and that's a post-op result. The incision is always transverse. So through the same incision we are able to harvest. And many of the trauma patients also now we do LD harvest. If you want to do in a lady, we do it in this manner. It is quite comfortable. You can go up and down and then take a big skin island, also transverse skin island. This way it doesn't come when they even wear a sleeveless blouse, it will get hidden. So donor side morbidity has to be kept in mind when we do latissimus dorsi. Indications, incisions are periocular to excise the tumor, and we do a transverse incision, horizontal scar, so that the scar is hidden. And of course the disadvantage is need to turn the patient, and you need to take care of seroma. But if you are very good in meticulous hemostasis, good drain, and good anchoring of the skin to the underlying chest wall, then the amount of seroma is much less. The other two popular flaps are LICAP. I think there is a presentation also. LICAP and ICAP. So LICAP is basically lateral intercostal. These are the perforators. We also sometimes use it when we do for flap cover in trauma for upper extremity, for the arm and the upper extremity. So this is a defect. That's the amount of tumor which has been excised. Again, we need to plan in such a way that first we Doppler and we allow our oncosurgeons to completely excise it. Doesn't mean that if you are doing a local option that the excision should be inadequate. So we fully excise it. That's the volume loss in the upper outer quadrant. And that's a flap. So the LICAP flap can be nicely harvested. A large flap can be harvested, deepithelialized, brought inside, and that's a pre and post-op result of a LICAP flap. Coming to ICAP, this is an intercostal perforator, and this is the same perforator which Dr. Dushyant mentioned many times. You can have a big perforator in the second and the third intercostal space where you can use it also to for our DIEP flaps also instead of going for the internal memory. So the size of the flap perforator is quite sizable. So we raise it in this manner. You can raise it, primary close the defect. Actually the defect comes right in the inframemory crease, and then deepithelize. That's a perforator seen there. So you deepithelize it, and that's a nice bleeding seen at the end of deepithelization. We don't do normally ICG in such cases. The bleeding is quite indicative of good vascularity, and that's a meticulous subcuticular closure is done. And this is very important so that it prevents it from going down and maintaining the crease. So this is an example, another example of an ICAP flap. So flap is raised, deepithelized, pre and post-op outcomes. Now finally, the round block technique, I think we saw also in the morning. So I will skip this part. So we go through a perioreolar incision, we excise it, and then take the tumor out, and then go all around it, and then close it. So to conclude, all women breast cancer cases, I think, should be offered primary reconstruction. Immediate reconstruction is ideal because actually it cuts down the cost, because if you offer a secondary reconstruction, that's an added cost. If the tumor breast ratio is more than 20, I think you should do some form of oncoplastic reconstruction. When we plan the surgery, we should consider the incisions in such a manner that our flaps perforators are not violated in any manner. And preoperative Dopplers and as many investigations, I think, as is important to get the pedicle correct. Thank you very much.